remain healthcare personnel and long-term care facility residents, but it's possible we might see a bit more detail added to that. That might give a bit more clarity and guidance on what that phase 1A population really looks like. Phase 1B and 1C might be different phases, or these might actually be combined. So we're waiting to see what that looks like. But if it's broken out to 1B, 1C, we're expecting it to look something like essential frontline workers, which includes first responders and those in sectors that are deemed really critical to the function of society. What does that mean? Food, water, electricity, transportation, these different aspects that are critical for society to function. It should be noted too, though, that this would not include those persons, well, it would include, but the priority wouldn't go to those persons that are teleworking. It would be those people that are actually at risk. So all of these phases, that whole phase, all those personnel are able to receive in that phase. However, it's based on priority for highest risk. So somebody working directly in a COVID ward would be at significantly higher risk than somebody possibly working in a normal ward. The one thing I want to draw your attention to is phase 1A, 1B, 1C is all red. And if you look at the top, it says limited supply, or what we would call scarce supply. So the thing I wanted to note is that we're expecting phase 1A to take some time to move through. We're expecting to take at least a month, if not longer, probably more like a month and a half. And why do we not have an exact timeline? Because that's based on allocation of vaccine. So for phase 1A, for this first week's distribution, we're expecting roughly 109,000 doses to the state. And why do I say roughly? Because that can shift a little bit depending on that final shipment approval from Pfizer, but we're expecting 109,000 roughly. So if you do the math and you look here, the population for the state in phase 1A, the estimated population, I should say, excluding Chicago, is about 580,000 people. So if you subtract 109,000 from that and think about future weekly allocations, you can see how it can take some time to work through that 1A, then subsequently 1B and 1C if the 1C is put in, or it might be possible they combine 1A and 1B. Why is the state of Illinois a separate population from Chicago? That's because Chicago will be getting their direct allocation. So out of that 109, approximately 24,000 of those vaccines are earmarked for Chicago. So there'll be two operations. We're collaborating and coordinating hand in hand. However, Chicago is going to be responsible for the city of Chicago in terms of operations and logistics. And then here at IDPH, working with our state partners, we're responsible for the rest of the state. So as you can see here, phase 1B, again, we're expecting those essential workers. Phase 1C, we're looking at those adults with high-risk medical conditions like chronic obstructive pulmonary disease, COPD, or heart conditions, or things like this, maybe organ transplants, things like this, and possibly adults 65 years of age and older because they are part of that vulnerable population. Phase 2, we're thinking it's going to look something like workers and industries that are important for the function of society, so like restaurants, banks, hotels, salons, exercise facilities, factories other than food. So for instance, a meat processing plant would be deemed, that critical function to society, or possibly maybe another factory that's not producing something that gives sustenance, something you need to survive on, might be in that later phase 2. And then we're thinking people with those moderate comorbidities or those underlying medical conditions. Phase 3, we're thinking of it may be young adults. We have children listed on here because that's where we expect children would be. However, we're not expecting the vaccine to be available for children, at least in these first phases. It's possible that ACIP recommends the age range start at 16 versus 18. So again, we'll get more guidance on that. And I just want to temper this entire chart with this phase that says, is pending ACIP recommendations, but possible groups could include. So as soon as we get this information, we'll be updating our plans and communicating that with our partners. And it's going to be, frontline news, I'm sure, around the world, in particular the United States, because we are receiving a lot of those questions asking, hey, this population or this work group here, which phase would they lie on? So the good news is we'll have clarity on that shortly, and that's most likely going to be on Monday. The one thing I did want to note, PIO, what does that mean? That's a Public Information Officer in Communications. I just wanted to note that they are working on a vaccine campaign to get the information out there. So if you go to the IDPH website, you can find on there these FAQs that answer a lot of questions. So if you check out the IDPH COVID website, you'll have that as well. And there is also a virtual joint information system that's active. And that's basically joint information and entities working together, IDPH, with IEM, et cetera, to try to get the messaging out there to folks and answer a lot of those questions. So that's really a quick overbrief. And Allison, if it's okay, I kind of wanted to open it up to some questions because I'm sure there's a lot of questions out there in terms of maybe what I covered or some other questions that aren't related to what I covered.
Yeah, Andrew, that sounds great. To all of our participants, please feel free to put any questions you have either about Andrew's presentation or something that wasn't covered by Andrew's presentation in the question box. We're happy to answer as many as we can during the time allotted. We will go ahead and start, though, with some questions that were submitted in advance of this call. So first, Andrew, can you talk about in distribution, of the vaccine, if this is being delivered to the hospital by the local health department and the hospital is administering, should the hospital be expecting to receive 2 vials for each employee that wants to be vaccinated to ensure that they will be able to have their second dosage in 2 to 3 weeks' time?
Yeah, that's a great question. So a couple updates or clarifications on that. So the vaccine the state is receiving is in 5-dose vials. So if you're vaccinating 1,000 people, you would divide that by 5, and that would give you your total vial allocation, which would be 200 vials, and that's in that example. However, I think the question really relates to should facilities be withholding that second dose for that hospital to ensure either 21 or 28 days later, depending on the vaccine, that employee can receive their second dose? And the answer is no. So what's happening on the federal government level is whatever allocation they make for the state, they're keeping 50% of that back, sending 50%. So they're going to ensure that if we vaccinate 100,000 people now, within the time allotted, that there'll be an additional matched allocation provided to the state. And then in turn, we will check our distribution systems to push it out to those providers to match that original allocation to get those patients their second dose. Additionally, there's CDC vaccination cards that are provided in each of these kits. So each of these hospitals through the local health departments are receiving ancillary supplies. And part of that ancillary supplies is a CDC vaccination card that is used to capture that first vaccination type, the type of vaccine, so then the second one can be scheduled and administered. It should be noted, it's also going to be part of the person's electronic medical record or their medical record system, but the card is just an extra step, an extra reminder for that person to ensure that they go back and get their second dose, because you're not protected to the level. So for instance, Pfizer is a 95% efficacy, so 95% effective if you get 2 doses, right? So the key there is we do want people to go back and get that second dose.
The next question is, can counties receiving an allocation of more than 975 doses that have ultra-cold freezers from the regional distribution site pick up that supply in the original shipping container in order to maintain the cold chain?
Right. Week 1 allocation, no. But week 2 going forward, we expect that to open up and have more options to do that. The initial allocation is being pushed centrally, and that is being pushed in larger Pfizer boxes that have nearly 5,000 doses. So there's really not an option to break it down to those 975. However, moving forward, we can and we are working to do direct shipments to providers. So for instance, Moderna, we're expecting that to come online probably a week after Pfizer, and that can be direct shipped because the first reason is their minimum allocation is only that 100 doses. So it's much easier to get that to jurisdictions with the scarcity of vaccine and a lot of folks not hitting that minimum threshold of 975 with Pfizer, with Moderna, they do. So we're direct shipping Moderna. We expect to do the same thing with Pfizer. We expect with each week's allocation, those allocations to increase to present us with that opportunity to do more direct shipment in that regard. However, with this first shipment, we are working on some direct shipment where possible and feasible. However, it's not going to be available for everyone who does meet that 975 threshold. And the thing that should be noted too is that it has to be increments of 975. So for instance, if your allocation was 1,500, you would have one full tray, but Pfizer's not going to, ship half empty trays. So you would either need to only get 975 doses or have enough to hit that next 975. So that's what's really complicated that operation. We know jurisdictions really do want that ultra cold, and we are working, tirelessly to make that happen. But we expect to see that capability to continue to grow and increase as the weeks go, because we expect to see that allocation number rise. So when will that change? That will change when the allocation of vaccine exists to where many more organizations or jurisdictions qualify for that 975. And also too, Pfizer's working on a smaller shipper box, so then they could issue smaller shipments, much like Moderna is doing. So the thing to note is that for this week one, the majority of vaccine shipping from the state RSS or the Strategic National Stockpile, as soon as it leaves the SNS, it's going to be at that 2 degrees Celsius to 8 degrees Celsius temperature range, which is really refrigerated vaccine. So as soon as it leaves the SNS, that's the start of the 5-day countdown that jurisdictions have to get that vaccine. We know that can be challenging, and we're attuned to that, and we're taking steps to deliver ultra cold where possible and feasible. And we do expect to see that capability to grow as we move into the second week and even third week allocation. The thing to note is we have our emergency response coordinators for IDPH reaching out to the first 50 counties who are allocated to ensure, hey, this is the allocation you're getting. Based on your local plans, can you utilize this within 5 days? Because the last thing we want is for a single dose of vaccine to be wasted because perhaps the uptake was not what they're expecting, or perhaps something occurs to where they have extra vaccine left over. So we're really working with local jurisdictions to assess and have them assess their local plans, their target populations, and really communicating with the hospitals to say, hey, your allocation is 200. Can you provide me with a list of those 200 persons that you know for sure are going to be able to get that vaccine? And again, what I noted earlier, we expect phase 1A to last for some time. This is not a sprint. This is not a race. And if it was a race, it's more a marathon. Our goal is to vaccinate as many people as possible to get the widest range of vaccinated individuals across the state as possible to, head towards our trajectory, our goal, which is hitting that herd immunity.
Wonderful. Thank you, Andrew. Is there any chance that the vaccine will be distributed on the weekends? People are asking in case this may affect their staffing plans.
So we're working tirelessly to make that not happen. It is a possibility. It would not be this weekend. I have a survey going out today to some jurisdictions to ask that question, how challenging would that be, et cetera. With phase 1A being healthcare personnel, the thought is that those healthcare personnel are going to be working. However, we are seeking more information in that regard. In the event that we did have to push it out during a weekend in the future, we're trying to gather that data now to see how big of an impact that would be. But we will always deliver it during business hours, and we'll always take steps to ensure that we're giving the most notifications / heads up as possible, and also, working to deliver that vaccine on a day that's going to, lead to success at the local level. Because again, we do not want to vaccinate, or we do not want to lose any vaccine due to perhaps it being a holiday or after hours or something like this, to where it's not able to be given. So we are working on collecting that data across the state to see what that weekend delivery looks like. That way, if that situation does come, that we have that data and we know if we would want to push it on a weekend, or if perhaps we'd want to hold it to a Monday. So we're working that line of effort right now to determine what that looks like. But again, we will not be shipping any vaccine this weekend.
Thank you. Can you clarify the state in which the vaccine will be distributed, either ultra frozen, thawed, or other? Some have heard that health departments are planning to distribute the vaccine that is already thawed and want to confirm.
Yeah, that's true. So we'll be receiving it ultra cold to the centralized location in the state. We'll be distributing it at 2 to 8 degrees Celsius. So we had heard some stuff out there before where folks thought it was -2 to -8. It's just 2 to 8 degrees Celsius, and that can be held in a vaccine cooler. Once it leaves the SNS and it's being distributed, the vaccine cannot be refrozen to ultra cold, and it cannot also be kept in a vaccine freezer, which would be like the -20, which is what Moderna requires. So this vaccine can only be held in that ultra cold around -80 degrees Celsius, or that refrigerated, which is the normal refrigerated range for vaccine, which is that 2 to 8 degrees Celsius. And again, once it leaves the SNS, it has that 5-day countdown to get that to individuals. And again, we are working on this and working with the CDC and our other partners to get more access to ultra cold for those jurisdictions that have that capability. And just to show you that we're working towards that goal, we distributed 10 ultra cold freezers regionally across the state to increase that local capability. So when you're working with your local partners, identifying those ultra cold supply chain opportunities within the jurisdiction, within hospitals or local health departments, or even other partners like possibly universities, is a good thing to do now. So you can start to formulate that in your planning efforts. So once we start having that capability, that can be increased. Now, if you don't have ultra cold, but we do a direct shipment to you, will come in that Pfizer box, and that can stay in that state for up to 15 days as long as you're refilling it with dry ice pellets. I believe it's 12 to 16 millimeter dry ice pellets. There's information on Pfizer's website on the size of dry ice, but that could be done for up to 15 days. But here's the thing. In these initial phases, we're in phase 1A with extremely scarce supply of vaccine. We do not want institutions holding that vaccine for long periods of time, because the point right now is to get as many people vaccinated as possible. However, we are working to increase that capability should a weather event happen, or should something happen to where that vaccine can't be used in 5 days. Again, we do not want a single allotment of that vaccine to go bad. So we're working in that regard to with the partners to, one, make sure that they can utilize that allocation within 5 days, but also to working to increase capabilities around the state to provide more opportunities for that ultra cold allocation.
Thank you, Andrew. So the next question has to do with security measures. What state-provided security measures will be available to staff at the hospitals once the vaccine arrives? And will there be police escorts from the local health departments back to the hospitals as they transport the vaccine?
Sure. So at the state level, the Illinois State Police is providing security from the centralized location at the SNS to the RHCCs. And then they have worked and coordinated with local law enforcement to provide security from the RHCCs to those local health departments. In terms of additional security measures from the local health department to the hospital, that's included in the local health department plans and their unique characteristics to the different jurisdictions across the state, because it looks quite different. For those jurisdictions that don't have adequate resources in terms of law enforcement to support the operations, ISP will be supporting those operations in that regard.
Thank you, Andrew. And your last answer may have answered this question, but where is the vaccine being sorted for individual hospitals at the HRCC hubs or the local health departments?
No, so let me go ahead and switch the screen here to show you a little bit more of what this looks like. Let me see. Okay. So this picture on the top left is the Strategic National Stockpile. That's 10 ultra-cold freezers, which holds approximately 1.5 million doses. What you see here is 2 boxes. So what's going to happen is this will all be pre-boxed at the SNS and will be sorted for each local health department. The boxes will be marked with the county health department, and on the other side, the RHTC hospital will be going to. So this helps get it to the end point. The brown box is holding ancillary supplies, needles, things like this, alcohol preps, syringes, etc. The white box holds the vaccine. This little box on top of it taped has a portal cut in it, and there's actually a thermometer logger in there, and you can see here this is what it looks like. So that at any time during the shipment, anyone can look into there and confirm the temperature is being maintained. And again, normally you want to keep this from 2 to 8 degrees Celsius. However, coming from the SNS, we'll be taking it from -80, so it's going to be much colder in that box. But as we ship it, it's going to gradually thaw up to that 2 to 8 degrees Celsius. But as soon as it leaves the SNS, that's the starting point of that 5-day clock countdown. So that is kind of how that's working. And the key thing here is the box should not be opened until it gets to that end point. So some local health departments will be taking it straight to the hospital because there's many counties that have one hospital they've identified, whereas other local health departments may take it back to their facilities, break it up into 2, 3, 4, 5 different boxes so that it can be transported to hospitals. But it's important if hospitals have the capability to, if you have a portable vaccine cooler, again, that keeps that 2 to 8, and your own data logger thermometer, it would be great to utilize those resources. So it's less taxing on the local health department. So definitely reach out in that regard if you do have those capabilities, because again, that will greatly assist with local logistics. And while we're talking about ultra cold, again, I just wanted to mention this vaccine cannot be kept in a vaccine freezer. So Pfizer cannot, Moderna can. So this vaccine either has to be kept at ultra cold around that -80 degrees Celsius or the 2 to 8 degree Celsius refrigerated temperature. 2 to 8 timeline, the life of the vaccine is 5 days. Ultra cold, it's 6 months.
Great. Andrew, would you be able to talk about expectations for documentation of the chain of custody, as well as what role eye care will be playing in the distribution of the vaccine?
Sure. So to be able to utilize the vaccine and vaccinate people, you have to be enrolled in eye care. It's a two-step process. You have to be enrolled in eye care and you have to be a pandemic provider. So if you're a facility that's receiving vaccine in this first week's allocation, please, please, please make sure you're a pandemic provider in eye care. If you're not, you should immediately reach out to your local health department and let them know and start working that to get registered as a pandemic provider. They will take that information, funnel it up the chain through our ERCs, and then we take those to our eye care team and we have them prioritize right now hospitals that might not be fully enrolled, but they're supposed to receive an allocation. So if you're not first enrolled in eye care, then second a pandemic provider, please, please, please start doing that now because you need to be enrolled to get that vaccine. And what was the first part of the question again, Allison?
Yeah, the first part of the question was documentation of the chain of custody of the vaccine.
So there's chain of custody forms that's going to follow the vaccine from the SNS to the LHD level. And then we've also included forms at the LHD level that they can use those forms or they can use their local forms, which will track the chain of custody from them to the end facility they're going to. So hospital X or hospital Y, so they can utilize that form to track where that's going. Ultimately, the vaccine is going to be completely tracked in eye care. However, that chain of custody form is meant to track it through the distribution as the ultimate receiving facility will have that allocation in eye care. So we just want to track that it gets there. And again, that box should not be opened at any time unless it's breaking it up to take to multiple hospitals or at the end hospital. And at that time, an inventory, et cetera, can be conducted. But just know all these boxes and shipments are being triple checked at the SNS to ensure they have the actual allocation. And again, just remembering that each vial is equal to 5 doses. So if you're receiving 100 doses, you divide that by 5, and that would be how many vials you'll be receiving.
All right, great. So we will go ahead and move on to some questions that were submitted during the presentation. So first, Andrew, can you talk about whether the state is planning to release training modules for staff that are administering the vaccines, as well as just information on how to store, how to handle the vaccine?
Sure. So there is already information out there. It's being provided by Pfizer, and we have been pushing different materials out. But if you actually go to the Pfizer or Moderna website, there's a lot of documentation and information on training, handling, the step-down process, so how to, thaw it, to prepare it to get to actual patients, how long it can last, how long the thawing takes, how long you'd have to take it out of the refrigerator to bring it up to, to make it to multiple doses. And then once that's done, how long the lifespan is. There is a lot of information out there in that regard, but perhaps, Allison, I can provide you with some of that documentation that could be shared after this fact, but just know that the information that's most up to date would probably be on that website.
That sounds great. I'll be happy to distribute that and get that information out. All right, so we have seen that there's going to be some flexibility and expansion of the scope of practice for AEMTs and EMTIs for administrators, as well as pharmacists, pharm techs, and dentists from IDSPR. Does IDPH plan on expanding the scope of practice to EMT basics?
Sure. So just a little clarification there. IDFPR is not covering the EMS. The EMS is under IDPH, and simply what it is, it's information that's been shared with all the EMS medical directors of the process they need to take to enable their advanced EMTs, their paramedics, and their EMTIs to be able to help and assist in those local vaccination efforts. So that has been provided to them as well as the local health departments on how that needs to be done. There's a set criteria they need to do, like creating a plan, a safety plan, continuing education, et cetera. But at this time, we are not looking at expanding the EMT basic, which is now known nationally as EMT without the basic, but we're not looking at them being that category being able to do that. It's going to be strictly for the paramedics, the advanced EMTs, which are now what paramedics are, and then EMTIs. So a lot of these names have been consolidated and changing. So that's why you have paramedic, advanced EMT, and then EMTIs have been phased out across a lot of the United States, but there's still, a substantial number of them out there.
Okay, thank you. So are hospitals expected to vaccinate independent physicians who work in the hospitals, or are they only expected to vaccinate employed or contracted healthcare practitioners?
Hospitals should look at vaccinating anybody who meets that definition of Phase 1A that works within their facility. So whether that's contracted or others, if they're in your facility and working, they should all be included in that Phase 1A planning. And again, as it rolls out and there's limited allocations, you'd base it on that highest risk. So if I'm local health department and I call you and I say, hey, we have an allocation for you of 50 doses, we need you to find your top 50 personnel at highest risk, that's up to you to look at that and quantify. And certainly anyone working within your institution should be covered in that. And the one thing to note too, that can be paid and unpaid, and that's not only physicians, nurses, and techs, that could even include the environmental personnel who's, say, cleaning a COVID ward or cleaning those rooms of the COVID positive patients. So it's for those healthcare personnel, including those support staff, that are at the highest risk. So that's an important thing to note there. And then also on top of that, there's been some questions, and I'm sending out a clarification a bit later today to the local health departments. This first allocations directly for hospitals, and the directors and governors plan on this for the 50 counties with the highest death rates was looking at those counties and those people who are, the most effective, and the ultimate effect is death. So that's why the intention was to get it to those 50 counties and then get it to the hospitals for those healthcare workers that are working in those conditions to try to break that chain of infection and also increase the continuity of operations there. It should be noted that EMS personnel can also be vaccinated in this first week's push, but vaccinated through that hospital. We know there's a lot of EMS-based or hospital EMS-based systems. We also know that EMS spend a lot of time in hospitals, so I will be pushing that clarification out a bit later today to local health departments. But your local planning for your hospital, you can include those EMS personnel in that as well.
Thank you. The next question gets to the doses and when they're received in which shipments. So one of our listeners has asked, they said they received information stating that on week 1, their shipment is large, week 2, greatly reduced, and week 3, it was the same allotment as week 1. Is week 3 considered to be the second dose for week 1?
So there's more information on that coming, but what I can tell you is that there will be matched allocations to cover those persons that need that second dose. There's nobody right now who knows their allocation for week 1, for week 2 and 3. Only those that knows for week 1. There's estimates and conjecture based on what we're expecting from CDC allotment. But again, that's all subject to change based on further information. It should be noted we're expecting an increase in week 2 because that's when Moderna we're expecting to come online. So again, nobody truly knows anything past week 1 yet, but that information will be forthcoming, I think, in the very near future. But for your planning assumptions, whatever your first week allocation is, I would base off that number and maybe build in a factor of 10% or something like this, just to kind of give yourself future planning. And then whatever that number be, you can adjust, or ends up, you can adjust proportionally so you can make sure you're prepared. And we are expecting to see allocations increase as weeks progress because we are expecting, pending any updates or change from CDC, to see that supply of vaccine to continually increase. And again, you really want to get granular at your level. We do not want one wasted dose of vaccine, especially when it's so scarce. So I would even get as granular to saying, okay, our allocation is 50 doses. Let's identify 50 people, and then even go to those people and say, hey, we want to put you on this initial allocation of vaccine. Are you willing to take it? The vaccine is not mandatory at the state level. It's voluntary, and we're not sure yet what that uptake percentage is going to look like. We have ideas and anecdotal evidence from around the state based on that viewpoint, but we are gathering more data in that regard, and that's something I encourage you all to do too. So if you're contacted by a local health department and given an allocation, that you can ensure you can actually give that. One more thing I wanted to note, if there's ever going to be a situation where vaccine is going to be wasted and you've hit all those personnel within that 1A, there is latitude there to go to the next party group down in terms to not to waste that vaccine. But that's something you would want to do, working with the local health department and notifying them that, hey, we've got 10 doses here that are going to go bad, so we're moving out of phase 1A into this next population. Again, we don't expect to see that occur for some time, but we don't want a single dose of vaccine going bad or being wasted because folks said, hey, we have to stick strictly in 1A. So there is a little bit of latitude there in the plan so we don't waste any vaccines. So just to push that into your local planning efforts there as well, because again, we do not want to waste a single dose. And you might build into your plan to where maybe you're contacted by another hospital or by a local health department saying, hey, facility X has extra doses. Are you going to be able to take those? So I'd build that into your internal planning as well, having some sort of surge capacity to account for a possible reallocation of vaccine if a facility or a department or any kind of provider in your area ends up having vaccine that they know they're not going to be able to give. Because again, the thing we really want to avoid is that wastage of vaccine.
Great, thank you, Andrew. So there seems to be some confusion about some of the different methods of tracking. So one question is, do hospitals need to register the patient through the EMR in order to give the patient the vaccine?
Well, the information on the patient has to be reported to eye care. Some institutions do that through EMR. Some institutions enter that manually into eye care. And some institutions, it has to, ultimately that data has to come to eye care. So however your institution does that is how that needs to be accomplished.
Can you clarify who will be providing vaccines to in the long-term care facilities, if it's done via CVS and Walgreens or other?
Sure. So there is a program, it was a federal partnership with CVS and Walgreens to handle vaccine operations for long-term care facilities across the United States. And it's actually a really great program. It covers everything from storage, handling a vaccine, to registering, to actually having people, a team, go into these long-term care facilities and vaccinate people. It's not only the patients or the residents there, but it's also the staff. And they will actually go there 2 more times, once you've gotten you have 21 days or 28 days for the second dose, depending on which vaccine it is. And we'll see more information and clarification come on that from ACIP, probably on Monday. But they will even go there several times to make sure everybody's received their second dose. It is a great program. It's greatly reducing complexity at the local level and letting local health departments and other jurisdictions really focus on other populations. We've already indicated to the CDC that we want to turn that on immediately. Their vaccine allocation comes out of the state allocation. So you have to have enough to start that so then they can start vaccinating all these facilities. And we've had the majority of facilities in the state sign up. So we're expecting that to probably turn on plus or minus a few days. The 28th of December is when we're expecting that. Again, it could be plus or minus a couple days there. So more information will be coming on that. But we've already allocated future vaccine allocations to get that program turned on and to get that population vaccinated as quickly as possible.
Great. So, Andrew, does Pfizer list anywhere the contraindications to taking the vaccine? Where can healthcare providers find that information?
That will be forthcoming from ACIP and post-EUA approval. So we'll see those contraindications. And for instance, if like a pregnant or a breastfeeding mother can take it, all that information is going to probably be coming out Monday.
Is there a consent form that's available for the vaccine distribution or included with the vaccine distribution?
No, so the consent form should be handled at that local level and how your jurisdiction executes that.
So is eye care tied to, and I may butcher the pronunciation, VTRAX?
Yep.
And Vaccine Finder, or are they supposed to register the vaccines on those separate sites independently?
No, so eye care is integrated into VTRAX, so it reports that required federal data back to the CDC. In terms of Vaccine Finder, I'd have to speak to one of my colleagues who has more visibility in that program than I. But I do know that eye care will be linked to the federal reporting system so that that federal data could be pushed from eye care.
The next question is, what happens if hospitals are unable to obtain a cold storage fridge in time to receive vaccines?
So let's hold that question. I actually thought of something right now I wanted to mention. When you're vaccinating, and once information comes out on the EUA or from ACIP, we'll be able to know how many people have side effects and what those side effects look like. And initial information we've been hearing, it's that somewhere around 10 to 15% of people, for one day will feel like, have body aches and things like this. So when you're working on your local plans there for the people you're going to vaccinate, you would not, you would want to be cautious about maybe vaccinating all your ICU nurses at once. You'd want to do it in a phased approach, just in case you have people that have those, those limited side effects and what we're hearing is 24 hours or one day. And again, we'll have lots more information on that Monday. But as you're planning now, it's good to phase it out so you're not doing one entire population or another. That way, if people do have those side effects and feel sick for a day, you can continue your operations and you don't end up with folks that are not feeling well. So I just wanted to mention that. So really you want to kind of spread it out to a few different populations so you're not just focusing on one, so that you could continue operations if, for instance, part of those people getting that vaccine just didn't feel well for a day. So I just wanted to mention that. And then can we go back to that question again?
Sure. The question was, what happens if hospitals aren't able to obtain cold storage fridges in time?
So the good news is, and not the good news for a lot of people, but the vaccine, again, is being pushed to that 2 to 8 degrees Celsius temperature. So that's a normal vaccine refrigerator. So any type of vaccine refrigerator you have that keeps that 2 degrees Celsius to 8 degrees Celsius will maintain the integrity of that vaccine for 5 days. Now, we're going to be increasing capability to where we can ship ultra cold. So either A, you could acquire ultra cold. B, there's companies out there that are renting them. And there's actually something came across my desk today, and I'm by no means endorsing this at the state level, but UPS actually has a leasing program. It's called UPS Healthcare, and they're working with Sterling Ultra Cold to where you could rent small, medium, and large size ultra cold coolers on a monthly basis. And again, that's not an endorsement, but just something that came across my desk. That's a capability. If you don't have that capability or can't acquire it, you can reach out to your local health department or the other partners to see if there's people you can partner with, to be able to have that capability. So again, if it's ultra cold, that protects the vaccine for up to 6 months. If it's that 2 to 8 degrees Celsius, that's that 5-day time frame we're looking at.
What supplies should hospitals expect to receive in the ancillary boxes?
Well, I can tell you because I was just sorting through it. We just actually received our ancillary supply yesterday here, so we're sorting through that and starting to build kits. So it's going to include the. So I'm going to speak on one vial, right? So one vial is 5 doses. So for one vial, you're going to see 5 of the CDC cards to track the patient's first and second dose and type of vaccine. And segue, if someone receives Pfizer, the second dose must be Pfizer. Someone receives Moderna, the second dose must be Moderna. You can't mix, has to be the same vaccine. So that's why that tracking, that medical record, and also that card are important. So for one vial, which is 5 doses, you're going to get 5 1 milliliter syringes with needles on them to deliver that. You're going to get 1 3 milliliter syringe to help prepare that vaccine, 1 vial of diluent, 2 alcohol preps per person. So so that's 5 packs of 2. They're connected. Alcohol preps to clean the vial and then clean the person's arm before you give them that vaccination. What else? And that's it in terms of everything per vial. But also what's going to be included is some minor PPE that we're giving to the local health department level. And by minor, I mean like some face shields, a pack of surgical masks, and some gloves, and just some gowns, but it's nothing significant. It's just meant to give to the local health departments to support their local operations there. So primarily, you're going to have the needles, the syringes, the alcohol preps, the CDC cards to track the vaccine, and then whatever additional PPE we might be able to put in there. But again, the PPE is not meant to support the entire operation. It's just meant to augment and support the local health department in their operations.
Thank you, Andrew. Does IDPH plan to authorize standing orders for vaccine administration if recommended by ACIP?
I don't really have information on that, so that's something we'd have to circle back on.
Okay, that sounds great. So do we have details, or could you go over some of the exact data points that hospitals and other providers will need to be submitting through iCare? The question at hand is if providers can record this information on paper and then submit it through iCare at a later time, they want to make sure they have the right information.
Sure. So that's something that would have to be shared from the iCare team. But you can contact your local health department and they might have more clarity on that. That way, we're not sending them a million emails to the iCare team because they're already receiving a million. But yeah, that information does need to be gathered. And it is set fields that they have that information on. So maybe even Allison offline, we can get that and get that to folks they know. But there is a requirement, and I believe it's within 24 hours, that information does need to be entered in iCare. And then the inventory, so every day you'll have to complete an inventory on how much vaccine you have, at the end of that day and how much was used. So those are two things that do need to happen.
How can hospitals tell if they're a pandemic provider? Is it the same as a special project provider? And if hospitals are not a pandemic provider, how do their employees get the vaccine?
So first off, there's two steps. You have to register in iCare, and then there's a second part, which is becoming that pandemic provider. You're a pandemic provider if you've signed the agreement with IDPH that basically states that the vaccine has to be given according to ACIP CDC guidance following the phased approach. So if you haven't done that, you're not a pandemic provider. What you need to do is reach out to your local health department and let them know, hey, I'm not a pandemic provider. Here's my hospital name, here's my hospital address, and here's a POC. And then that can be forwarded up to the iCare team so they can be looking for that to prioritize that. But you would need to start that process yourself by going to the iCare website and first becoming registered in iCare and then clicking on and becoming the pandemic provider. If you're not a pandemic provider, you're not going to be able to give store, hold, and give vaccine at your facility. So the number one thing you got to do is register on iCare and become that pandemic provider.
Thanks. So a lot of hospitals are mentioning that they will be planning to have appointments scheduled on the same day that the vaccine is sent to be able to use it in a timely manner. What should hospitals expect in regards to notification so that they can plan ahead?
Yeah, that's a good question. So we are going to notify the RHTCs and local health departments ahead of time, and then they will then do their other notifications there at their level for the hospitals. What I can say is we plan to give as much notification as possible. I think worst case scenario would be a 48-hour notification from us to those local health departments, and then whatever that looks like there at your level with that information being shared. We are also, concerned about security. So we're trying to be careful in how much information we put out there in Telegraph. So when you are notified, it's nothing you would want to, put on social media or put out there ahead of time. That's something that you would want to keep within your facility for your planning purposes, but also knowing that you wouldn't want to release that ahead of time. So you will have a heads up. Again, we're expecting to give minimum of a 48-hour notice to the RHCCs and local health departments. And I encourage you to get with your leadership and your comms folks to work out how you want to release that information there at your facility, knowing that you should really keep that security in mind. And by security, it's usually advisable not to be like, hey, we're receiving the vaccine at this date and this time, just to be cognizant of that so you can do those operations without any kind of interruption. And again, there's no active threats or anything we're looking at in the state. It's just acting out of an abundance of caution and planning every single aspect of this vaccine distribution so that it goes off without a hitch. And there's no additional concerns in that regard. So just something I wanted to mention there for you all in terms of what that looks like.
We have a question here asking if the vaccines can be commingled in storage with other refrigerated medications.
Sure, and I think that's information that's going to come out on Monday with ASIP. I have not heard any guidance in that regard yet.
Thank you, Andrew. So one question is in regards to the expected amount of time to deliver from the SNS to the local county authority.
It's going to be quick. Our intention is to get it to the LHDs at the start of the workday. Our intention is to have the most of those 5-day, that 5-day window possible. So by the time they get back to the local health departments, it might be afternoon for some, it might be morning for others. It just depends on where they're at and their driving distance from the state. So again, probably that second day, most certainly, you would be able to start vaccination operations, and possibly on that first day. So I think that's a discussion if you take back to the local health department and have that discussion on what that looks like. That way you can plan accordingly. And especially with phase 1A, you have a little bit more latitude of planning because it's really those staff in your facilities that are going to be scheduled versus say like the general public. That would be a lot harder to maybe shift it one day. So for instance, on that day one, if you had that planned, but you're in one of those jurisdictions that's going to get it a bit later, maybe you're doing an evening operation or maybe you plan to do it the following day. So I think it's really working locally to look at what that looks like for your local situation to see, when you're expected to receive that vaccine. So reaching out and saying, hey, if you receive the vaccine on a Friday at 11 a.m. or 10 a.m., how long is it going to take you to get it to us? And then that will give you an idea, an estimate, knowing. But again, a lot of things change. A lot of things are evolving with this response to COVID-19. So I think having a little bit of leeway in your planning to where if somebody gets a flat tire or if vaccine shows up an hour or two later, that it's not going to be detrimental to your operations, that you just have to augment appropriately. And that could also include arriving early. That's also a possibility as well. So really strong planning needs to take place in terms of especially that first day clinic you're hosting, to have a little bit of leeway and play time in there to where you can adjust appropriately depending on what it looks like on that day.
Thank you, Andrew. Well, I want to be respectful of everyone's time. It is 12:30, so it is the end of our scheduled time. I want to thank everyone for hopping on. Andrew, thank you for your presentation and thank you for going through all of these questions. I think this was immensely helpful to hospitals across the state as they anticipate what the next weeks and months are going to look like. So we have recorded this webinar. The link to the recording will be sent out once that is available. And of course, I am available for any questions. I know the Hospital Association is available to send anything additional to me to work through. So again, I want to thank everybody for your time, and I hope everyone has a good weekend.
Thank you. See you all later.